Care task team here in Cape Town and in the Western Cape. She's also a mother. She lectures on with the undergraduate curriculum and also supporting some of our postgraduate students. So over to you, Dr. Morgan.
Thanks, Jennie. Just checking my screen is sharing.
It's sharing.
Okay, great. Okay. Good afternoon, and thank you for joining me. I'm at work, and I hope my PC is and my connection is good. If there's a problem, please let me know. Okay, so I'm going to be presenting what we've been doing in Hayterveld with regard to our palliative care project. I'm presenting this, but there's a team behind me who have been involved with this project. The team consists of Renee Krauser from IPCM, Kat Evans from Emergency Medicine, Maggie de Swart and Portia Williams from IPCM, and I'm strictly from Family Medicine. So that is the team. Okay, if we go back to 2021, early in 2021, Renee and Tracy Nalede approached province to ask for a site in which palliative care could be strengthened and have a palliative care training site that would happen from the community to primary healthcare district level and would refer to Goedeskeer. And so after a few discussions, it was decided that the Hayterveld community would be the site that UCT could develop. And so late in 2021, we had a workshop with all the stakeholders. So there were people from UCT, there were people from the facilities, from the substructure, as well as the community who joined together to discuss what do we need to do to achieve this goal that UCT had for a training site. The outcome of that workshop was that we needed to strengthen existing palliative care services, and then we needed to do quite a bit of training of these existing staff members, as well as the NPO staff and the community. So just to give a brief outline of the communities that we're talking about, Hayterveld and Manenberg suburbs cover strictly Ward 44, 45, and 46. And they, as you can see, roughly just over 100,000 people. But as you can see, different areas have different population densities, and some are very dense and others not as densely populated. If you look at the map, those of you who don't know Cape Town that well, we've got the airport, and if you're driving along the N2 towards town, then the little blue block on the left of the N2 as you're going towards town on the south side is where Hayterveld and Manenberg are. They are serviced by an 8-hour primary healthcare facility, the Hayterveld CDC, and the Hayterveld Emergency Centre is also in the same area. Although it services the whole of Klipfontein, it is based at Hayterveld, and HEC also has an overnight ward of 30 beds. We are supported by the Klipfontein Mitchells Plain substructure and the community-based services. The NPO that is contracted to offer our community-based services in the area is the YMCA. At the start of this project, there were no formal palliative care services, as St. Luke's Hospice does not offer services in this area. And so this is a neglected area within Cape Town and with regard to palliative care. So we started having a few engagements with some community members who'd been at the first workshop. And from that series of engagements went forward, partly these engagements involved sharing information about existing services. So there were misconceptions and confusion among some community members about the existing services. So we were able to rectify those misunderstandings. And through the discussions, it was highlighted to me the gaps in service, the patient flow, that there was needing to be existing services needed to be strengthened, and patients that needed more information, and the community wanted more training. This term, "there's nothing more we can do for you," is a horrible term, and we would like to change the narrative for our patients. And I hope that we are slowly changing that narrative. At this time, we applied for, so at the end of 2021, we applied for funding from Discovery Health, and we were granted a Discovery grant to start up this project. So we started looking at strengthening palliative care services. At HEC, there was an emergency medicine consultant, Kat Evans, and an MO working in the ward, Portia Williams. Both had their diplomas in palliative medicine. They worked on quite a few things. There's a direct admission to the overnight ward bypassing EC for any known palliative care patient. So if a palliative care patient arrives at the front door needing admission, they don't wait on a stretcher in the EC, they go straight through to a bed, especially those patients who possibly are pre-terminal. To pass away on a stretcher or a chair waiting to be admitted to an EC bed is not fair. So there's a very rapid admission to the overnight ward, which for many patients has been a huge relief, and people have been able to pass away with dignity in a calmer environment than the EC. In the ward, Portia has worked really hard with the social services, and she has a DG book and a granted application book in the ward to assist patients who are bedbound and too sick to be able to attend a doctor's appointment for a DG application. We also were able to receive more staff, and the overnight ward was accredited as a family medicine district hospital rotation, and so the Mitchell's Plain interns rotate there as one of their district hospital placements. They worked on some stationery, and they have a summary tool in the folder just looking at the important things during the admission. This is really good stationery. I also use it in the day hospital. We also networked with the Cancer Association. With the lack of other NPO support for palliative care in the area, we networked with Cancer and found that they had a social worker who was willing to do home visits as well as come to the ward and see patients. And she has been such an asset to our team, and really willing to go above and beyond for our patients. So we work really closely with Abida and are grateful for that relationship with her. Portia works really hard on initiating a VULA referral for down referrals of discharged patients back to primary healthcare, whether it's to me, who's literally across the passage, or to Hanover Park, or Guguletu, or to Dr. Abdurrahman, depends where the patient comes from. And they're really good. The whole team is really good at down referring patients who are palliative, so they can come on an appointment, not just arrive at the clinic with a letter, but actually come for an appointment with a named healthcare provider and the right healthcare provider. So they come to somebody who is trained in palliative care. In the clinic, at the time when we initiated this, I was not at Heidelberg, but since then I have moved to Heidelberg and I have my postgrad diploma in palliative medicine. I have a regular Thursday morning clinic, but I also see patients on other days, depending on the need. And I've got various team members that I can refer to as needed. I've got a social worker and a social auxiliary worker, I've got an OT, a physio, a dietitian, and then I've also got staff in the community who I can refer to. The butterfly that's on the screen at the moment is a stamp that I use to stamp each folder and appointment card of any patients who are palliative after they have been informed that they are in need of palliative care. And this identifies to the rest of the team in the facility that this person is palliative and therefore should be fast-tracked at reception. They shouldn't wait in the non-appointment queue. They shouldn't wait at pharmacy. They need to be assisted as soon as possible. And this year I conducted a few sessions with, when I say lay staff, I'm talking about the reception staff, GAs or cleaners. There were even some kitchen staff from HEC who attended, and also the pharmacy staff, to understand, when I say pharmacy, the pharmacy assistants, to understand what the butterfly means, what palliative care means, and why I'm asking for these patients to be fast-tracked. There's been a significant change since I did that training with the other staff members. We also learned that we were not assisting patients with health net bookings, and so we were able to improve that and organize transport to hospital for appointments for our patients, especially patients getting chemotherapy. And we work quite hard with community-based services. So YMCA is our NPO, and we've been supporting and training their staff. And then from our substructure, we also have other healthcare workers who support our team. So we have community rehab workers and a community occupational therapist. We also have a community-based social worker and social auxiliary worker who work closely with our palliative care team, amongst other things. So some training, which was the big outcome from the initial workshop. At HIC and the CDC, all the MOs have had the basic 40-hour training in palliative care. And many CMPs and PNs have been trained, but not all of them. There's a PN in the overnight ward who has just completed a certificate course for 9 months in palliative care nursing, and that has made a difference in the ward. All our allied health staff members have had the 40-hour basic training, as well as our social worker and social auxiliary workers have attended the psychosocial 40-hour course. At YMCA, our NPO, all the PNs have had basic palliative care training for the 40 hours, and then some of the CHWs have had carer training, but we need to train more of them. We have also tried to implement mentorship in the overnight ward. Hasn't been as successful as we would like, but we will review that and move forward with that. So having the medical interns in the overnight ward also means that we can train them on practical palliative care things. The overnight ward has syringe drivers that's able to deliver subcutaneous morphine, and the interns learn how to set those up and administer them. We have various undergrad medical students who've come through since the project has started. Last year, we had 2 third-year students doing the SSM project, and I'll briefly present that. Then we had some 4th-year health and context students doing a community project and developing some pamphlets for us, which I'll also show you briefly. Maggie brings the 4th-year health and context students to the overnight ward for a TAT regularly, and each week we give 2 TATs to the 6th years. So in the overnight ward between Maggie and Portia, they manage that tutorial, and then I have a TAT at the CDC with the cancer social worker who joins me for that TAT each week. We've also had various elective students and monumental registrars through the program since we have set it up. So just briefly, this is the research that the SSM students worked on last year. We presented this poster at the PALPRAC conference in April. I presented this at the FaCE Research Day, and we are in the process of trying to get this published. Then the 4th-year health and context students worked on 2 pamphlets, What is Palliative Care and Grief and Bereavement, and this was with Bahia, their supervisor. In March this year, we had our first community training session. We had 20 community members, and we had lots of discussions around what is palliative care, the myths around palliative care, managing pain, how can I as a layperson help, and where can I access help. From this training that we had, there were some recommendations. They asked for more training, for more community members to be trained. They asked for informal carer training, and this is where a family member or a neighbor is caring for somebody who's in need of palliative care, but they feel that they need more training. They need to be more equipped to do this. They also asked for family member support because their family members really battle watching their loved ones die, and then bereavement support. So middle of this year, we initiated a support group one for Heidelberg, one for Manenberg, once a month. My community social worker and community occupational therapist run these 2 groups. It has not been as well attended as we hoped, so we need to reflect on that and see what we can do to improve that moving forward. And then as we speak today, they are doing the first 2-day family carer training course in Heidelberg. They've got 25 people present to do some discussion and practical skills on how to look after somebody at home. So Corinne Payne, who's part of the staff in IPCM, is running that. And as soon as I finish here, I will go and join her the rest of the day. When they asked for bereavement care as well, we have been in touch with one of the churches in the community offers a grief counseling course. And so I put people in touch with them and network, and thus networking with my community who are already doing some work in bereavement. So the funding that I mentioned earlier is that we got the funding from Discovery. We used this money to do various things. In the facility, we assisted with renovating the boardroom so that UCT could use it as a training site. And this boardroom is shared between UCT and the facility. Then we put an EduRoam into various parts of the facility so that students would have access to Wi-Fi when they were on site. The SSM project last year, we used some of the money to pay for the statistics for that analysis. A large amount of the money from Discovery has gone on training. We paid from that money for the PN to do the certificate course. And then we paid for CHW training, and quite a few staff who went on the 40-hour course, their funding came from this budget. The 6-year teaching that I do along with the cancer social worker, Abida, I'm not paid, but Abida is paid an honorarium from this budget as well to attend the tutorial and assist with the teaching. It has been hugely valuable to have her join us. She has got years of experience of being a social worker in various contexts, but in the last 10 to 15 years in palliative care with cancer, and adds a huge wisdom to the tutorial with the 6 years. And the feedback has been phenomenal to actually be able to engage with a social worker, which it seems that they haven't really had much engagement in their 6 years with a social worker, and finding out from the social worker what she can and can't do. The community training in March and the community training today was supported by this budget as well. And I think this training today and tomorrow is finishing the rest of the money. But last week, when Renee went to Joburg, we were the winners of the Discovery Institutional Award for 2023. So it looks like we are doing really good work. We just need to find some more money. So moving forward, we need to strengthen palliative care services further. We need to continue to improve access to care. There are always people who are missing the care and don't understand how to access it. So we need to continue to improve that. We need to continue to improve the community knowledge around palliative care. And we need to do more training for community members. We need to make sure all our staff are trained, as well as the fact that there are always new staff rotating or coming into the facilities. And so we need to continue to train them. It's been on my to-do list for a while that we need to look at spiritual counselors, and I hope in 2024 I can address this and see how we can have a network of spiritual counselors for our area that has varying religions, but a wide range of spiritual needs that need to be met. I'm looking forward to working with the Department of Social Work at UCT and seeing how we can work together on this project. We need to ensure that this project is sustainable. If Kat, myself, and Portia leave, that we need to make sure that this doesn't fall flat. So we need to make sure that it's not just us driving this project. And we look forward to training more UCT students, both undergrad and postgrad, in the coming years, hopefully not just MBCHB, hopefully in social work as well as other disciplines. Thank you.
Thank you very much, Jenny, and thank you for all the hard work for you and Portia and Kat and Maggie that you are doing every day. Are there any questions? I'm going to start with a question then. Jenny, what community engagement is really becoming one of the important things, and what have you learned about the palliative care that you've been taught, and after engaging with the community, how can we actually strengthen our palliative care teaching and our awareness about palliative care?
So I think that there are, we have palliative care at Curtis Care, we have palliative care in the communities. We think we're doing it, But there's so many patients who are falling through the cracks. There's so many patients who people don't fully understand. It's still cancer patients getting care over and above the patients who have organ failure, dementia, and even we talk about trauma as in burns, but I also think of trauma as the spinal patients. So the paraplegics who are not getting care as well, because no one thinks of them as dying, but they are. And so they're falling through the cracks, and then sort of not knowing where to go, where to access care, not knowing who to get it, where to go and get it from. The community cares. So our community is amazing and caring for each other, coming to get medication for other people. The amount of many people who come to my room with a patient and I ask them who they are and they say they're the neighbor. So it's, people are caring for people who are in need and they're not related to them, but they care. And it's amazing. They need support, and it's not just the family needs support, the whole community needs support. Yeah.
Thank you very much. Liz, your hand is up.
Thank you, Renee, and thank you, Jenny, for that really interesting discussion, and congratulations to you both and to the team on the program and on the Discovery Award. I'm really encouraged to see the way that not only the teaching, but the clinical delivery of palliative care, the holistic care, is being provided. And I know that was a big gap because of danger areas. St. Luke's weren't there as a hospice. So my questions are kind of two, I suppose. The first one is that, so this for me is a model primary palliative care site. What are the plans for other primary care facilities to integrate palliative care as thoroughly as you have, so that it's a seamless kind of way of patients receiving care? And I suppose the other one's not so much a question, because I see how you are training family members and community members, but that has always been the response in communities, that the neighbors care for others, or that a mom who's lost a child will care for others. So there is that wonderful compassion that's available that you seem to have been tapping into in the community. But how are we going to expand this further?
Thanks, Liz. It's difficult to speak for the whole province, but we are trying to establish palliative care in each facility. And I can speak for our substructure in that every primary healthcare facility has a palliative care program. It's only ourselves and Hanover Park that don't have access to St. Luke's and possibly areas of Philippi. So we do need to share the learning that we've had in Heidelberg with them. But as a substructure, we do meet every 2 months to discuss what's happening and try and encourage our colleagues to provide similar care. It is, I think Heidelberg is probably further along the journey than some of the clinics, but everybody's on the journey somewhere. Definitely the learning that my team in the community have, so my social worker and occupational therapist who are doing the support group, they don't just work in Heidelberg, they work across the whole of Klipfontein. And the social workers from Mitchell's Plain, from the community-based services in Mitchell's Plain, have also joined our support group to learn, so that the intention is to also roll it out at Mitchell's Plain side as well, so that there is an intention to share the learning that we're having in our side. I know that the training that we're having today and tomorrow, the community training, is new, and Karine is sort of finding her feet. But we're using this one as a pilot, and we will be writing up the sort of learnings that we've had from today and tomorrow with a proposal of how to move forward. I think Renee and I are hoping that Karine takes us forward as an MPhil, and I will just speak out of turn for her. But definitely looking at how we can create this, and whether we as an IPCM team or FaCE team take this further, or whether we package this and hand it over to province. I'm not sure. it might be for now that we need to keep doing it, rather than handing it over at this point. But I'm not sure. Yeah, we'll need to see how it goes going forward next year. But we would like to do more, and potentially in other geographic areas, not only in Heidelberg.
Thank you. Yeah, that's exciting news.
Louis Jenkins.
Yeah, thanks. Thanks, Jenny. Thanks, Renee. Jenny, thank you. Amazing work that's happening there in Heidelberg, and also congratulations of that Discovery Award. I'm thinking two things that we're battling with. Maybe you have some insight or experience. The one is how do patients after hours, we've been toying with the idea because, people are in need of advice or reassurance or something to phone in, because increasingly we're battling always to get to everyone with a home visit or follow-up visits. I mean, we don't want people to have the hassle of getting to a clinic or definitely not the hospital just for some reassurance or adjustment of treatment. So we just don't know how to develop a sustainable sort of phone-in service, to something like that. The second question is around data. We have quite good data on how many patients are being referred to our palliative care team. This is in the Garden Route, in the George sub-district for others on the call. I know our setup, but so how do we? But we don't get good data from the community health workers who visit patients at home and give that feedback who's passed away now or who've moved out of the area, so that to answer the basic question right now in our service, how many patients are in active palliative care? It's a sort of not a clean, and it's tricky because they're not formally part of the health service. Because ironically, the Department of Health wants good data, but the community health workers sort of fall slightly outside the Department of Health. So it depends a little bit on the clinic sisters, the OPMs who manages the community health workers. But I don't know what you guys have done around robust data.
Thanks, Louis. The after hours question, if I had a solution, I would have shared it with you. If we had a solution, it would be province-wide, but we don't have a solution. Lots of ideas, but I think budget is an issue. If we could have an after hours service, that would be fantastic, but it's really difficult. I was hoping that with all these PMs that have been employed around the province, we could start something, because now we have people on the ground who could be on a call roster, and at the same time we're getting budget cuts. So there goes that idea. Yeah, so I don't have an answer at the moment, just looking at having sort of a phone in the facility, not the normal phone with the reception supposed to answer because no one ever actually answers that, but a dedicated line that someone's going to manage. So I'm looking at setting up a WhatsApp line that will be looked at 3 times a day, that we can then respond, because I can send a CHW to the house within a couple of hours if I know there's a problem there, but how do I know there's a problem?
Exactly.
So, and that would happen during office hours. So we're looking at setting that up. I'm happy to share that with you once that's up and running and it's working. But that is not after hours. Yeah, I think it's something on all our to-do lists, to keep applying our minds to it. And I think now that we've got the manpower within the province, the question would be financing it. So financing a core roster. Yeah, my idea was that, the poison center is manned by people, pharmacists, I think, at the first line, and then there's doctors on the second call if the first line can't answer them. And so we've got enough manpower to do something like that, but it's the money. Data, I know Renee maybe wants to speak. Renee's got a red cap database at Interdisciplinary, but I'm not sure how they manage the active patients. No, they definitely manage the patients who've been referred to them. We also manage, I have my own database, but it also is sort of, it's my own thing. And what we are working on is the provincial SPV palliative care report. So Kat and I are working with Florence, who's at PDC, on that report. I pulled the report earlier in the year and found a whole bunch of concerns that I raised with Florence. So on one report, patients are duplicated because they've been identified as a morphine receiver and then a cancer patient. And so they're on the report twice, which makes it very difficult to use because you can't just say, well, the bottom number is that number of patients because it's duplicated. You've got to sort of sift through the data, which is unpleasant. So we are working with Florence on that. Other issue is that patients don't always, what I've noticed is that I know that they've died, but if I go on to Clinicom or FaCE or SPV, the data doesn't match. So it can say on FaCE that they've died, but it doesn't pull through to SPV. On SPV they've died, but on FaCE they're still alive. So it's not, something is not pulling through. So we do need to work on that. But that database on SPV is only successful if we use ICD-10 coding. So what I would encourage your team at George to do is on discharge, on ECCR, to use the palliative care ICD-10 coding so that they can be flagged. They flag quite easily the cancer patients, but they don't, and the renal failure patients, but they don't flag the dementia, the cardiac failure, the COPD patients that well. So if at hospital level, we can start discharging with the ICD-10 coding on ECCR, it will flag to SPV and make that report more robust. And I do have access to pull that report for province. So if you want to have a look at it sometime, I'm happy to share it with you.
Thanks, Jenny. Okay, thank you.
And Louis, feedback on that report, any help to the data center would be useful as well. I think when that report is more robust, we can look at doing some research on it. But at the moment, it's in its infancy still.
So just to let you know, the report is based on algorithms, and the algorithms are based on the likelihood of using other data to determine whether a patient will require palliative care. For example, if a patient repeatedly has a eGFR less than 15, then this patient is most probably a palliative care patient requiring palliative care. So I agree we're going to have to depend on the ICD-10 code, but if we really want to understand the palliative care situation in our province, we are going to have a wider look. And it would be, and I agree with Jenny, it's really as she said about what we are learning is that actually there's a huge gap in actually who gets palliative care and has access to palliative care because many patients are not identified as being for palliative care. So ICD-10 codes will not be the only way we can look at it. We'll have to have a wider look at how we identify patients. Yes, Louis, one more.
Yeah, sorry, last comment. I don't want to, but yes, exactly. But I'm sure you're also having it. What we're finding as we're trying to get to integrate our data more is that there's there may be quite a few patients outside the formal system. We have some of our community health workers who will just on a weekend do some home visits. So that's like almost their own care ethos. And then again, yeah, so, I mean, not for now, but some app in the future where community health workers, if they've been in a home, to just do 5 or 6 clicks on an app that pulls through to a database, like things like a Trello, for example. The Vula app doesn't quite do it because you need to have a HP, professional number and stuff. So again, it cuts out some of the community health workers. But an app where they just say, geomapped, I visited this person today, passed away, or morphine finished, or need spiritual support, then that will that will start telling us, sure, there's an area, where we're visiting that is that there's a specific service need or anything. I think at the moment it's sort of driven from the facilities rather than from the homes. So I would love that. That we know from the homes there's a way to collect data that is at point of care, not because also what happens is we're sort of saying, listen, if the community of workers, what all the activities you did this week on Friday, please manually update this in your clinic with the OPM. So we all know then that means some of the data is lost, yeah.
Thank you. No, I agree with you. Point of care
Yeah.
data is what we really need. Taslim?
Sorry, Renee, Louise, one of the things I also see is patients so the patient is at home, potentially bedbound, they actually are contained and they haven't got symptoms that need to be resolved, but the family needs support.
Yeah.
And so they're palliative, but they're not coming to the clinic because they don't think. And the family think, why am I bringing that? What's the problem? But they need more support. And they kind of fall through the cracks because they haven't come to hospital, they haven't come to the clinic, and so they're not on the database. They haven't got a folder or a recent visit. And you see it when you review the patients who've died at home. They die at home of a natural cause, but they haven't been seen for the last 3 or 4 years. But surely they needed care, and even if they didn't have symptoms, surely the family needed support at this time. And even if it's to say you're doing a good job, they doesn't have to have needs, but they still are palliative and we should be caring for them.
Yeah.
Taslim?
Sorry, just an idea that came to me while Louis was talking about this app. And first of all, I must say, well done, guys. I'm really proud of the work that you're doing. Impressed. This app is a good idea. I think, and I want to go a step further and say, the first the first point of data entry should be with the patient and not with the first health worker. And if you think about your friends, Renee at Discovery, if you think of a typical Discovery client is able to access an app on their smartphone, it might be useful to think about how do you have a kind of an app which incorporates both families and patients and staff members, so it doesn't only become something which staff members can access. It's an interesting idea, and I suppose it's at the stage now with this kind of blue sky thinking about how do we connect people who are maybe kind of all over the place. Something to think about.
No, I agree. And I think, we've done this pilot project now on showing that palliative care is definitely viable and successful in a community healthcare center. Now we've got to go and show how it's actually viable in the whole COPC structure so that we can move out from there. I want to ask any more questions. Because I do think there's one thing we need to highlight as well as one of the important members of this team is the EC. And I know some of our emergency medicine colleagues are on this call as well, that we have to really work alongside our EC staff members and our people going out to work to the houses, the ambulance worker, first aid responders, and to go out to the homes and in the homes, and how are we actually strengthening that kind of teaching and training and managing phone calls. Any other any other questions? Charmaine.
Hi, Renee. I kind of feel like I have to represent emergency care quickly. I think we know, and I think that is some of Lindsay's research, but we know that there's a huge gap in especially the pre-hospital environment, and also that patients are transported when they don't necessarily need the transport, or that they're taken outside of the area to another facility than where they are known, and also just generally the training. So I definitely agree that there is a huge gap in what we are doing and how, or what you are doing, and it's amazing work that you're doing, Jennie, and how to include EMS in the pre-hospital environment, but also how to include emergency centres, because I think often the patients are cared for there and they're discharged and they're not moved to be part of a program. And I know that Katja has done a lot of work on that as well. But again, it seems to be geographically located in one area that definitely has a need. But yeah, how do we take that beyond Mitchell's Plain and Heideveld area to other areas? So definitely, but what an amazing talk and what amazing work you are doing. Thank you.
Thanks, Charmaine.
Thank you. We are really looking forward to working really side by side with our emergency medicine colleagues to ensure that we really address that gap, because we know such a huge amount of patients are attending emergency centers actually requiring palliative care at home. Okay. Jennie, any further and last points or thoughts?
I think I just remembered when you were talking now that with regard to training community members, we are looking at training, I'm going to say the right word, the EFAR members in our community. So we just need to adjust what we are training, but there are volunteers in the community who've been trained by, I think by EMS, with regard to first responders, especially in the areas that there's quite in the red zones where the ambulances can't get in that quickly. Then there are community members who are trained, and we want to train them as well with regard to palliative care principles, so that when they're called to a house that someone is in need of palliative care, they know what to do. So today's training is predominantly older people. And so we need to look at how we can train the younger people who maybe it means a weekend when they're not working. But that is also on our radar.
Yes. And people are absorbing, as what we found with the community engagement, they are absorbing this training. They want it, there's a need for it, and I think it will make an impact really long time, because the people will stay in the community and know what to do. Thank you, everybody, and thank you, Jennie Morgan, for an excellent talk. And we hope if there are any other people working in CHCs or in the primary healthcare setting, that this can be a model for implementation and integration of palliative care in the primary care setting, and using education and using teamwork and to really ensure we are getting the care where it really needs to be. Thank you very much.
Thanks, Renee. Thanks for your leadership, Renee.
Thanks, guys. Bye-bye.
Thanks. Bye.